Kari, would you like to come to the front? Kari Bruffet is CEO and President of Kansas Health Institute. You can read more about her in the wonderful speaker packets that Mary put together. Would you like held? Okay.
Actually, that's a good idea. Why don't I have this?
Okay.
I can wander around a little bit. Yeah. And do you want me to just let you know about slides, or is there a clicker I should use? Oh, awesome. There we go. Well, good morning. I am Kari Bruffet. I'm the President and CEO of the Kansas Health Institute. So we are based here in Topeka. We are a nonprofit, nonpartisan health policy research and education organization. We are, as when the slides go up, I'll even show you a picture of our building. We're proud of our building too. This is gorgeous though, isn't it? Yeah, the Sunflower Foundation and the work that they do is so incredible for their community. So I know there are a lot of people in this room who are experts in food as medicine, and I know there's a lot of people in this room who are experts in rural health policy as well. So I come with some humility, knowing that I'm not necessarily either. I have had the opportunity to serve on the National Advisory Committee for Rural Health and Human Services, and so some of the slides I'll be using to kind of help level set us when we're talking about rural come from some of those conversations. And then the Kansas Health Institute. Oh, I'm probably holding that wrong. There we go. I was pushing it, making it go backwards. We've been around since 1995. KHI was founded by the Kansas Health Foundation, one of the conversion foundations in Kansas. And we are an independent organization, though. We work very closely with other partners, including other foundations like the Sunflower Foundation, state agencies, and other partners to convene tough conversations around health policy issues. Our office, if you saw the other view of our building, you'd look at the state capitol. We are immediately across the street. So one of the things I'll be doing, I'll be missing lunch because I'm going to hop back to our place to do something we call Health Bites, where we actually have conversations with legislators over a lunch hour on a Thursday during the legislative session, talk for like 10 or 15 minutes about a policy issue, and then ask them, what would they want to know more about it? What would they like to learn more? The policy issue today is about aging and aging in place and some of the policy issues and barriers to aging in place in rural Kansas as well as other parts of Kansas. So we also do a lot of focused work in rural health, and as we'll talk in a moment, sometimes when we think about doing rural health policy research, we're doing research on rural. We don't want to be just doing research on rural communities, but actually in and with and really in participating with our rural communities. And so I appreciate, and I'm looking forward to some of the panel discussions later where you're really talking about how important it is to engage those rural communities when we're talking about the specific challenges, but also opportunities. So my task is a little bit to talk about what is rural, but I usually like to start with what rural isn't. So rural isn't just like everywhere else, but smaller. It's not, and that means some of the policy challenges and opportunities and solutions are not just a matter of scaling. So I think that's important for us to keep in mind, but it's also not uniform. All rural is not the same. And you know that depending upon what part of the country you're from or what background you're from, rural is not equal or not all the exact same. And there are a lot of different assumptions about those communities, rural versus urban comparisons, and so then we lump all of rural together in a way that probably misses some of the nuances that we really have to appreciate when we're working in and with rural communities. So Kansas has this. Some of you may be familiar with it. Kansas has a rural definition for state programs that is focused on population density. So really tries to look even more closely at variations in population in rural communities. So the sort of turquoise and kind of those colors are the urban and semi-urban counties. Everything that's some other shade of green is something that meets a rural definition in Kansas. So the darkest green that almost looks black here on the screen are those frontier counties. That's fewer than 6 people per square mile. That's a lot of Kansas, and that's probably a lot of the communities and counties in the states that you all are from as well. Not as many people, obviously, per the density in those communities as some others. Then the kind of in-between color of green is folks 6 to 20 people per square mile. And then densely settled rural counties are the 20 to 40 people per square mile. Still pretty rural. And if you think about other definitions, census definitions of rural or metro and non-metro, even some of the communities that are densely settled rural or semi-urban are really pretty close to meeting rural definitions or non-metro definitions as well. And why is that important? So I use it, for those of you from Kansas, you may have seen me use this slide or some of the story before. This is my grandmother on the right and on the left. This is Pearl Stearns, my Grammy Pearl Stearns from Jewell County, Kansas, in north central Kansas. If you remember a Super Bowl commercial a few years ago, Bruce Springsteen drove to the center of the United States, the continental United States, and was in Lebanon, Kansas. Where she's from, Dispatch, Kansas, or outside of Dispatch, Kansas, is close to that. Or if you know where the world's largest ball of twine is, anybody know that? Cawker City, it's also close to Cawker City. So think of my grandma's story as something that kind of illustrates both the challenges and opportunities when we think about rural America. So she, on the left here, probably around age 5 in the late 20s, was born in the same house she lived in her entire life. And when she met my grandpa, and he actually came and took over the family farm there, and she lived in that same house every year of her life, except for like 2 years during World War II when she went out and taught in other rural communities in Kansas. She went to a one-room schoolhouse. My mom went to the same one-room schoolhouse through the 6th grade, and then high school in Cawker City. Cawker City doesn't have a high school. That one-room schoolhouse isn't there anymore. Cawker City's high school isn't there anymore. They consolidated in the 70s, and subsequently, even that high school has consolidated since then. So it could be seen as like a story of loss, like we've lost population and folks moving from those communities. But it's also a story of why people stay. So my grandma wanted to stay there because her social institutions, her friends, and her family, her extended family, not just her blood relatives, but others who were part of the Dutch immigrant community that had settled around Dispatch, Kansas, were still there. But her part of Kansas is very different than the communities I grew up in, all of which would be called rural as well by various definitions. I went to high school in a town that had 20 in my graduating class, Victoria, Kansas. But it's like 10 miles from Hayes. And if you know about Hayes, that's 20,000 people. It's got a college. That's where I went to college. Big town. Meets most rural definitions as well. So when we think about the kind of challenges that kept my grandma from being in her house till the very end of her life, when she needed to have some hospice care at the very end of her life, no service providers were available in the very rural and remote community she was in. My uncle had come home and taken over the farm and helped take care of her at the end of her life, but when she needed that extra care, she had to go to a county over to a nursing facility for just the last few weeks of her life in hospice care. Might as well have been Europe as far as she was concerned, because it was far away from where she was from. So her experience, and we'll talk about some of both the challenges and opportunities of rural, frames my thinking about rural, even though I'm from rural areas too. So rural definitions, and this, so you all are probably very familiar with this if you've done any work in rural. One of the sometimes difficult things about doing research in rural health policies, there are so many definitions of rural. And I think this map, this is from the Center on Rural Innovation, illustrates among 9 common federal definitions of rural where there are differences in our interpretations of what is rural. Everything that's light green is mostly rural, at least I think 4 to 6 of the definition, or 7 to 9 of those rural definitions agree that that's rural. So light green, north central Kansas, western Kansas, and a lot of the other states, if you're all in the Midwest, depending upon how we define the Midwest, and the Great Plains are also in that area. But everything that's like the red, there's another version of this map that just shows the red or orange. That's where there's most disagreement, where about half of the definitions say it's rural and half of the definitions say it's non-rural. And so that can be challenging when we're doing research and really thinking about the policy work. But it also just helps illustrate the vast variety in rural America. And then blue is mostly non-rural, so that's either going to be completely non-rural, there are metropolitan areas, or meet very few of the definitions. And then there's other ways to think about rural too. It's not just about population density. And when you're thinking about food and healthcare access, it's also about distance. So another measure that is used is the frontier and remote zip code areas. So I'm going to go through these quickly and not going to read each of the exact definitions because they're very precise about distance of population. But this level 1 is zip code areas that have most of the population in that zip code living 60 minutes or more from an area with at least 50,000 people. So those are sort of the dark blue areas. Now, as you kind of zoom in a little bit more, there's different levels. Now, maybe you're closer to maybe a slightly smaller city, or you're 60 minutes from 50,000 people, or 45 minutes from 25 to 50,000 people. And we think of frontier as being mostly the West a lot of times when people think about frontier, but this shows these, by distance anyway, these blue counties are, or zip code areas, are all meeting that same definition. Getting closer as well. This is also more distant, so the zip code FAR level 3 and then FAR level 4, which I will read that one real quickly for you. That's if you're, again, 60 minutes or more from 50,000, 45 minutes at least from 25 to 50,000 people, and you're at least, there's a few other ones, at least 15 minutes from even a town that has at least 2,500 people. So those are the sort of the most remote. A few years ago, I think 2018, the Washington Post used some international data to look at the most geographically remote areas or towns in the geographic or the continental U.S. So it excluded Alaska, which probably would have won a lot of this or been the highest distance from their areas of population. But they used a kind of an arbitrary other point of furthest towns that had at least 1,000 people that were the most distant from communities that had at least 70,000 people. And of the top 10, 4 of those towns are in Kansas, which was sort of surprised. The most ones were considered most remote, right? They said the name of it, the name of the article was Identifying the Middle of Nowhere. So again, maybe showing a little bias about rural defined by deficit instead of by what it has. But that's the counties and towns along the western Kansas border between Kansas and Colorado. But there are a lot of other communities, maybe not in the top 10. Montana, Nevada, and some remote parts of, or more rural parts of Texas were also part of that area. But in our region, Oklahoma Panhandle communities, a lot of Nebraska, the Dakotas, and so on. And some of the other areas, maybe why they didn't get ranked as being as remote is maybe they just didn't meet you have 1,000 people to start with in your community. So we know rural and frontier is not just the Mountain West. It is all parts of the United States, and particularly in the kind of Midwest, Great Plains region that we live in as well. Probably not unfamiliar to you all is the rural communities, or rural, and again, this goes back to the definitions. This is more metro and non-metro populations, right? So sort of the starkest definitions between the rural areas and not. In the decade between 2010 and 2020, metropolitan or the non-metro areas actually saw, and this, if you look at the chart, this is change it's showing, not the overall rate. So the line at 0 shows if you're any of those years, the line is under 0, there was actually population loss estimated. And across the entire decade, there was population lost in those non-metro areas. But you probably have heard this recently. Something did change in 2021, and it's continued in 2022 as well. So really, it turned around. So the population actually gained in rural areas. And for a while, it looked like in 2021, it had increased more in non-metro areas than in metro areas. I think they re-looked at the data, and it's actually more pretty similar if you look at kind of the maroon bar there for 2020 to 2021. But net migration changed in rural communities. There were theories that were put forward that maybe it had to do with the response to COVID-19, that people were wanting to get away from populated urban areas and concentration of population and get to rural areas. And with the expansion and the opportunity of more remote work opportunities that allowed some of that. So that's part of it. But you'll see something else, even though that overall trend was like, hey, that's a good trend. If you look at individual rural counties, it did vary. So a lot of the communities are rural, or the non-metro defined communities that benefited had proximity to more populous places, and then the kind of places that have access to care, access to more services, and or they were retirement communities or recreational communities in our rural areas. So it may be very different from what was happening in the county where my grandma lived for many years. In 2017, between 2016 and 2017, there began a real decrease in natural decrease, so the ratio of deaths and births in non-metro areas. And as we'll see in a moment, again, not to define by deficit, but that is probably likely to continue with just the overall U.S. Birth rate, the aging of the population as a whole, and particularly in our rural communities. But we also like to talk about aging not in terms of like a challenge to be overcome. There's opportunities for communities and rural communities particularly to be able to grow by maintaining the populations they have and then attracting new folks to their communities as well. That's probably going to have to be the case because it's not going to come primarily from births in those communities as well. So these are the population pyramids. This is from a few years ago. It's not shared to look at the specific numbers, more just the comparison. These are population pyramids. They're supposed to be pyramids anyway when you look at them. But if you look over to the right, those counties that are considered completely rural, I've always thought it kind of looked more like a Coke bottle or something. So you have the older age population is higher up in the chart. So it's a challenge, but it also is a definition of some of our rural communities. But if you look across the country, not all rural has this experience as well. And it's also not unique to rural. The mostly urban counties is not really much of a pyramid anymore either. That's also changing in the United States. We also have increasing diversity across the country and in rural America. A few years ago with Kansas, we looked at some of the population gain and loss in our most rural communities. And if not for net immigration, both domestic migration and immigration from outside of the United States, our rural communities would have lost significant population. Instead, they sort of held steady and in some cases grew because of that migration. This is also from the Center on Rural Innovation. This doesn't show the increasing diversity. This instead looks at and illustrates the point that diversity also is different. There's diversity and diversity across regions. So if you look at the Midwest region, for example, that's indicated in sort of the green. And that's not the percentage of the population that is of various race and ethnicity as defined here, but instead the composition of that overall population by region. Maybe an easier way to look at it is this. So Brookings did this based on 2020 data and looked at the largest quote-unquote minority groups, the largest non-white or Hispanic groups by population. So in the yellow community or the yellow coded counties, these are all rural areas. Gray means they're non-rural. So it's just looking at rural. The largest population that is Latino or Hispanic, defined as Hispanic, whereas in the South and the Southeast, the largest population, Black African American. You have in some parts, certainly of Oklahoma and even in Kansas and other parts of the Dakotas as well, that largest population is indigenous population. So there's even variety in our diversity, and we think about how in rural America, just as there is across the rest of the US. So we shouldn't make assumptions about it being the same. We're thinking about how we talk to one rural county where maybe there's not as much, the sort of the lighter shades of color, the less saturated shades show less diversity. But where there's diversity in our diversity. And then finally, I think I was supposed to talk about healthcare and access and so on as well, so I'll do this real quickly. But I know Kristine is going to be talking about this as well. So this is sometimes, again, I hesitate to want to always just focus on those things where we are talking about challenges in rural communities. So we're not defining by deficit. But sometimes you have to absolutely embrace the reality to be able to face the challenge. And so I know we're doing that with food as medicine as well. This is a graphic from HRSA as well that highlights some key points. And I have some slides to follow that sometimes are focused on Kansas and some national to give us a glimpse of what this looks like. So people in rural areas live 3 fewer years than people in urban areas, and there's higher rates of heart disease and stroke in rural communities. And again, it depends on your rural definition. For a lot of these, it's using a metro, non-metro definition. There's higher maternal mortality rates, also less access to obstetric care in rural communities, and a real challenge in our rural communities. Higher rates of some of the behaviors and factors that influence health as well. More limitations on access to care, There's tends to be in rural communities, although this also varies, less health insurance coverage as well, and that also varies, and that's changed over time. Long distances, especially in those communities that were those blue communities too, that's a specific challenge and a real challenge for healthcare. And then a real, and in Kansas particularly, and in other states in this sort of the swath of the high plains and the southwest or southeast, a real challenge for rural hospitals specifically. So I'll go through these very quickly. Maternity care, yeah, 50%. I think it says more than 50%. I think the most recent number is 56% of rural counties have no hospital-based obstetric services. And then I'll also point out that rural women of color are particularly at risk. That has a specific impact, not just on rural population, but in inequity and disparities within rural populations as well. A real challenge. This is the most recent, downloaded a couple days ago from the University of North Carolina Shep Center, their map and directory of hospitals, rural hospitals, that have closed starting in 2005. If you look at the bottom, this is the trend in hospital closures. You saw that up through 2020, it was a not completely always upward, but certainly upward trend in hospital closures. Kansas has 10 closures in that time period, 6 complete closures with the hospital entirely closed, and 4 where it converted to something else but doesn't provide inpatient services. And not yet including like the rural emergency hospital, where instead they just had to find some other thing to provide in their communities. We see during the early days of the pandemic, because of some of the policy, payment policy, there was a pause in the impact on the rural hospital closures. So in 2021, for a while I heard 0, but now there were 2 closures across the country and 6 in 2022. Now, 9 in 2023, and there already have been some in 2024 as well. So a real challenge for our rural communities where hospitals sometimes are not just the hospital, but they are a locus where other health services are provided. It's where the doctors may work. It's where community-based programs may originate from. It's where long-term care may be provided as well. So it's not just about the inpatient beds, it's about all the services and the ancillary services that often in rural communities are concentrated around a hospital. The rural health workforce, not like there's a surplus of a healthcare workforce really anywhere, right? But there is a specific challenge in primary care, the ratio for physicians as well as nurse practitioners, all primary care is more challenging in rural communities. And again, this is rural as defined as the non-metro, using that definition here. These are really small numbers, but I'll just point out the key point here. It's also a very stark challenge in non-metro communities for behavioral health access, a really specific one. I had a slide previously I also talked about in Kansas, the higher rates of suicide in our frontier communities specifically. So some more distinction in suicide rates in frontier communities, more difference there between frontier and other rural communities than there is between rural and semi-urban and urban overall. So a particular challenge of distance and access to care, and particularly access to behavioral health care. And some of the other challenges that come with being in a very rural community. Social isolation and the opportunity to be really connected to the community. That's what kept my grandma wanting to be in Cawker City, Kansas, or in the farm outside of Cawker City, Kansas, was that social connectedness. But that becomes more challenging as a generation's age, move, and fewer opportunities are available. Health insurance coverage, and this is Kansas numbers. We use, again, the frontier numbers. Overall, this is very similar to the national difference. It's maybe the urban, semi-urban is actually a little lower than some of the other parts of the U.S., but the rural rate is usually about that gap. But we see, again, our rate for lack of insurance is higher in those frontier communities as well. But, okay, and I'll switch gears because I know I'm probably well past my time, and to talk about the opportunities too. So within all of that, those are real challenges. But despite, we talked about social isolation, in some of our rural communities, it's actually some of the strongest assets they have. KHI works on the county health rankings with the University of Wisconsin, prepares each year, but we are the Kansas partner, and we work with each county. And many years, the counties that have the very highest rankings for social institutions and social connectedness, so whether those are churches, social clubs, opportunities are counties that are heavily rural. Now, it's also the challenge in some of the rural communities where depopulation is specifically. So having opportunities to really engage with those institutions that do help support their communities, but also can be good partners in your work, I think is an opportunity. Also lessons from the COVID-19 pandemic, also all kinds of lessons of what we could do better, what we need to do better, and not great outcomes in rural communities, but also lessons about what we can do when innovation is demanded, when you have to get innovative because the situation says you can't have a PACE program, a program of all-inclusive care for the elderly that works the same way it did before if you have a pandemic. You can't bring everybody in. So what could we learn from that for rural communities that want to have the same kind of programs? Or telehealth, all sorts of new flexibilities that policymakers had held off on for a long time, and payers, and once we had to do more telemedicine, we learned what we could do well and what policies could continue. And then finally, I'll say there's other, not just those kind of innovations, but other opportunities when communities are faced with necessity. Necessity can be the mother of invention, and part of it is to share the resources. So KHI for many years was the home of the Center for Sharing Public Health Services, but that work has transitioned to FAB, but part of that work is also really focused on cross-sectoral sharing. How can a health department, a hospital, a community-based organization, and others share resources, commonly needed resources, so they can provide for their communities? And in a lot of the Midwest, you got a lot of jurisdictions. Kansas has a lot of counties, 105 counties, and so that can be a barrier, but can also be an opportunity to be able to have folks still maintain that ownership of their solutions in their communities, but also start to partner and think about how they can leverage resources of their neighbors. And so I think I'll end now because I think I'm well past my time, so I apologize. And we'll say that this, you all, and I can see this by the panels and the panel discussions, I'm really looking forward to learning from you all for the rest of today and tomorrow. But thinking about the opportunities to really authentically engage rural communities means we're just not researching on, or we're not coming up with policies for, but really trusting and getting to know the rural communities and leveraging what they have. Respecting some of their choices that might be different than there would be in other communities as well. So we're trying to learn that at KHI, and I know that all of you embrace that too. Thank you so much, and again, I apologize for being over time, and I really look forward to learning from everyone the rest of the morning.
All right, thanks, Kari. So as you can see, the theme of our first panel here is kind of some level setting to better understand just the nature of rural communities and the various systems and what that looks like. Our next presentation is from Kristine Sande from the Rural Health Information Hub. Kristine?
All right, thanks. Good morning, everyone. I am Kristine Sande with the Rural Health Information Hub, and okay. And if any of you are not familiar with the Rural Health Information Hub, we are the nation's information center on rural health. We are located at the University of North Dakota, and we are funded by the Federal Office of Rural Health Policy. So all of the resources that are available through the Rural Health Information Hub are free for the users. So if you haven't checked out our resources, I'd encourage you to do so. We have a very extensive website, as well as information specialists who can help you find information if you call or email. They're happy to do that. And we do have an online publication called the Rural Monitor, and coincidentally, we just put out an article yesterday about produce prescription programs. So if you haven't had a chance to read that, I'd encourage you to do that as well. So I'm going to talk today just a little bit, very briefly, about diet-related disease, and specifically chronic diseases that have a dietary component. So chronic disease is typically considered a non-communicable disease that lasts a year or longer, and requires ongoing medical attention and impacts daily life. And so the diseases we're talking about today are chronic diseases that also diet can affect getting the condition, but also can affect how well you do once you have that condition. So, you know, and kind of top of mind diet-related diseases would be things like diabetes and heart disease, obesity, and also some cancers. But many chronic diseases have a nutrition component, even things like chronic obstructive pulmonary disease or dental diseases and osteoporosis. So it can be pretty wide-ranging as far as nutrition and chronic disease. So this is brand new prevalence data that the CDC put out just probably in the last couple of weeks. And I was so fun when they put out data that has that rural-urban split because we don't always see that. So we're always happy when they cut the data that way for us. So what you'll see here is in non-metropolitan counties, there's higher incidence or prevalence of diabetes. But what's really interesting to me is when you look at it, it's the younger age groups where the disparity really exists. And by the time they're 65 and older, actually, the metropolitan has a higher rate of diabetes. But when you're 18 to 34, 35 to 49, 50 to 64, quite a bit higher rates in non-metropolitan areas. So, and what we know about whether people are being screened for diabetes, if they're getting those A1C tests, the Rural and Underserved Health Research Center, Health Research Center, put out a report in the last year or two that told us that in rural areas, people were 14% less likely to receive those A1C tests on that annual basis. So that tells us something about prevention, you know, and kind of flagging to people, hey, you might need to watch your diet and try to prevent diabetes because you're getting in that prediabetes range. And also, you know, helping people manage that condition once they have it is a problem. Also, in rural areas, it's less well controlled. Typically, once people have diabetes, there was a JAMA article in 2021 that looked at three Midwestern states, and they found people were 16%, or rural people were 16% less likely to meet the D5 metric of optimal diabetes control. So we have work to do. Also, this chart shows prevalence of heart disease and cancer. This is 2019 data from Health United States. And again, you see for both heart disease and cancer, higher rates in rural areas. Obesity is an interesting chronic condition. Just in the last few years, have people really come to see obesity as a chronic disease of its own right, rather than just a factor that impacts other chronic diseases. So we see really across all age groups that higher diabetes or higher obesity rates, all adults. The non-metro rate is quite a bit higher, also for children. And then with this slide, you'll see on the right, there's the obesity rate for 18 to 34. So again, much higher in that young adult group. And 60% of non-metro young adults say that they have a chronic condition. So that's really high. And something that we need to really work on. And even more challenging is when people have multiple chronic diseases. Becomes much harder to manage. So this study from 2020 showed that people in rural areas had a rate of multiple chronic conditions of 34.8 compared to 26.1 in urban areas. So that's a pretty extreme disparity. And of course, we need to also look at within rural populations, how do some of these things play out? So on the left are folks with 2 or more chronic conditions. The blue is Black people, orange is white people, gray is Hispanic people, yellow is Asian, Native Hawaiian, or Pacific Islander. And then the lighter blue is American Indian and Alaska Native. So you'll see that within or across the races and ethnicities, there are some pretty big disparities just across rural populations. And then the 2 charts on the right are really more access measures. So did they meet the colorectal cancer screening recommendations? And you'll see the white people have a much higher rate of meeting those recommendations. And then on the far right were people who reported not being able to see a doctor or other provider in the last year because of cost. So 25% of Black respondents said that they were not able to see a physician or other provider in the last year because of cost. And that might not be just the cost of care, but also maybe cost of transportation. There are multiple costs that go into seeing a physician, especially in rural areas where you might have to travel quite a distance to see a physician. Sure.
So when they ask that question, do they distinguish between primary care and specialty care? I mean, when that question's asked, so if like they were maybe able to see their primary care doctor, but when they got referred, they weren't able to get into that. So
I think the question's pretty black and white as far as, have you not seen a doctor in the past year because of cost? And people kind of make.
For our clinic, that's a different question.
Right. Yeah, I mean, I don't have a solid answer for you on that. You could look at this study, but I think it was pretty much just that was the question, and people answered it how they would. And then kind of what's the consequence of some of these different things as far as prevalence and how well controlled people's disease are. You'll see age-adjusted death rates across a variety of chronic disease, and in every category, rural age-adjusted death rates are higher. So some of the factors that impact chronic disease are things like healthcare access, healthy food access, social drivers of health or social determinants of health, depending on your preferred term. And that can be things like poverty, transportation access, maybe built environment, whether you can exercise, environmental health factors, and then health behaviors. And so this was another CDC publication about healthy behaviors. And so these are all considered healthy behaviors, so higher is better in this case. So non-smoking, higher in rural area, or higher in the U.S. overall than in micropolitan or non-core rural areas. The one that rural actually does better in is moderate drinking or non-drinking. So normal body weight, physical activity, and sufficient sleep are the other factors. So in my 20 years at the Rural Health Information Hub, we see a lot of models and best practices, grant applications, and different things that people are doing around chronic disease. And when I first started, I remember talking to the clinic manager from my rural hometown, and she was saying, we just got a grant and we can pay for, 25% of somebody's time to do chronic disease management where, they call and make sure people are coming in for their A1Cs or whatever. And that was, at that time, like a big deal. And so there's been this evolution in how we manage chronic disease in rural America, and I think we're making great strides. And with value-based care, I think more incentive for care coordination. But, from those slides, you can see we have a ways to go. So telehealth and being able to connect remotely to a specialist, remote patient monitoring in their homes. I've seen a lot of community health worker or community paramedic models where people are actually going out to people's homes and seeing the environment that they live in, which I think has led to a lot of aha moments in terms of what people actually live with and what's in their fridge and that sort of thing. Seeing much more awareness of the need to be culturally appropriate, and also education efforts to improve health literacy and self-management of chronic disease have been growing. So I'm excited for today's conversation about food as medicine, because I think that's just that next level. So here's my contact information if you want to connect. And again, I'd encourage you to check out our most recent article on prescription produce programs.
Thank you so much, Kristine. I will trade you. Thank you, thank you, thank you. And we are pulling up our final speaker for this level setting on Zoom, Dr. Julia Valliant from Indiana University had hoped to be here in person both yesterday and today. Unfortunately, 'tis the season for germs and colds, and so through the power of Zoom, I was just speaking to someone last night. I think Kate and I were talking like, Zoom existed in 2019, but we didn't really think about using it for meetings, right? I mean, it existed. It's only been since COVID that, we're like, oh, we can just always meet this way and not remember the conference calls where you'd have to, George has joined the call. So, okay. Hey, Julia, great to see you. Quick preface to Julia. People often ask if you're from an agricultural state. They think you literally just go out in your backyard and there's a cornucopia of abundant fruits and vegetables. But yet we have farm deserts, food deserts in farm country. So Julia is going to take us on a journey for how that happened. Thank you for joining us.
Yep. Good morning. Julia has joined the meeting. It's such an honor to get to be with all of you again today. After I spoke yesterday, I really appreciated your good questions about my work leading studies here in Indiana, in which we run and evaluate food as medicine interventions in rural places. Over the past 4 years, this work has served 500 people. We've been conducting it in 3 languages, English, Spanish, and Haitian Creole, to serve our growing communities of rural meatpacking workers. And we've conducted 1 randomized clinical trial about FIM with 60 people. And our positive findings are about to be sent into a journal for publication. Also, I want to introduce to you my colleague from Indiana who's in the room with you, Chelsea Simpkins, if you would please stand up and wave to folks. Chelsea has been involved in a few of the facets of our food as medicine work, and she's on staff with our university's brand new community engaged research center. And she's also a grad student in public health. So here's our third frame to consider in this morning's introduction as we all get going. All of us here are working together today and at home to connect more people with good food to transform their health and the health of us all. So now let us ask, why is this even a thing? Why in Middle America, a very fertile place on earth, do we need to link people up with nourishing food? Come on, computers. Okay. Because the part of the world that we're in is begging to grow plants and to grow life. So, according to this map from the US Department of Agriculture, green shows us the most arable soils on Earth, and blue, orange, and red soils are also very arable. So, we're not in an actual desert when we're this far east on our continent, which is a reminder that a food desert is a human construction and not some place the earth made for us. There are decisions and there is agency that cause food deserts to develop. So, why does our strong environmental endowment in farm country not always translate into good food access? I am going to be talking about this from the perspectives that I have, with an emphasis on the evolution of US agriculture and how that is affecting the rural Midwest. We are going to look at it from these four related levels: household, farm, retail, and structural. And these layers of influence all funnel into people's access to consistent, dependable, nourishing, and pleasurable food where we are in the rural Midwest. Access to food has always been challenging and uneven, even in farm country. And the blue star shows us where you are in Topeka. Kari, I was smiling during your talk because in my family, I also draw on my two grandmothers, Margaret and Peggy, as examples of differing access to rural foodways and the role of agriculture and nutrition. And you probably have people in your own families to help you ground these large concepts that I'm talking about. So Margaret and Peggy each grew up in farm country about 100 years ago. And even in that generation, these issues were in play. Margaret was raised on a peach farm in rural Arkansas. And then as a woman, she always gardened and she fished and she ate what she caught. She lived and was well for 102 years. On the other hand, we have Peggy, who grew up very poor in rural Indiana. Her family did not have land and did not raise food, and she also never did as a woman. This is Peggy in the middle in the white dress. She said one of her early memories was of her tiny child hands working the pellet of yellow dye into the packet of margarine to help it dissolve. And her life was shorter, which was too bad because she was very dear to me. Their foodways may have had a role in their health outcomes. These two rural women were on the cusp of the transformations that we're now fully within in agriculture. And as white women, they face none of the structures of racist discrimination that further separate people in farm country from food and have for hundreds of years, such that one of our country's early contemporary food as medicine interventions comes from the 1960s in the Mississippi Delta region, where the Tufts Delta clinics created by Jack Geiger's teams, their pharmacies stocked food along with medicines, and practitioners who worked there wrote vouchers for food at local stores. And later today and tomorrow, we will get to learn about food as medicine innovations by Indigenous communities. So today, rural places in the US possess less economic diversity compared to what you find in cities, which works out to less income inequality emanating from rural communities, which is good, and yet more poverty concentrating in rural places, which is hard. 90% of our counties nationwide that are struggling the most are rural, like with the generational poverty we're going to talk about next. Even so, we have a tendency to idealize rural places in terms of the good food and good health that should be found in them. This view of country purity became common as industrial cities grew. The country began to look very appealing from within crowded, coal and horse powered cities that lacked any systems for sanitation or water. So now we're going to move to look at the level of the family or the household. Of course, there is some truth to the view that country purity, because in rural places, we're more likely to have a piece of ground, like a yard, where we could raise some food. But home food production seems to be going down over time, even in rural places. Our research team did long interviews with older adults in our rural region of Indiana about how their food now compares to their food growing up. A couple of takeaways from those conversations are that one, home food production and hunger could coexist. And two, that something else they remember as being normal from their childhoods was for there to be a rhythm that alternated periods of abundance or having plenty of food with periods of scarcity. And nowadays, these periods fluctuate less on a seasonal calendar than on a calendar of when social programs run out, such as when school is out of session, like we heard about yesterday in Oklahoma's work to get summer meals to more kids, or when monthly checks or benefits have all been spent. A major change over time for food and families is that the things the adults are doing all day have shifted. We often have two wage earners whose time is committed to their jobs a lot of the time, and they may be away from home a lot of the time, which leaves less time for food, either raising it or cooking it or both. Now, the data that we see in the figure here are compromised because they only reflect married couples, but they show us that from 1960 to 2010, the proportion of single earner households was cut in half from 72% to 37%, while dual income households more than doubled, such that now 6 in every 10 households, everyone's working. Many more families are now straight food consumers and no longer producing food. Folks have made these changes because wages have stagnated compared to the economy, and people want or need to earn more money. Work schedules can be long or unpredictable or both, which makes quick, convenient, and prepared foods much more feasible and appealing. As an example of this, here's a quote from one participant in our Food as Medicine programs who said, "We have always ate out. I'm a nurse, so I work long hours. I work crazy shifts at the dialysis center. I get up at 3 a.m. and I'm there 10 to 12 hours, and I never know what time I'm going to get off. So by the time you've worked a long shift, you just want to come home and go to bed." And she said this doing the Food as Medicine program, where she got a meal kit and learned to cook it every week, pushed me to cook more. But her situation illustrates the long, unpredictable schedules. Another thing that's now customary or assumed is that for food not to cost much. In general, we like this in our country and we want to protect it. We view it as a marker of stability, and we want to safeguard our disposable income for other types of investments in the economy. So this figure shows from 1960 to 2019 how total food prices have fallen from us spending almost $1 out of every 5 on food in 1960 to spending about $1 out of every 10 of our disposable income, which is our income minus taxes. This slope reflects the same slope as the blue line, which is money spent on food that we eat at home, because food prices have fallen and we're cooking less. And a bit of a rise in food money spent on food away from home, such that now we're spending the same amount of money on food out as food that we take home. Now we're moving to the farm level. So in theory, it's no problem if you don't have food at home and you're rural. You could go to a neighboring farm or a farm market to get some. But the changes to farms are one root cause of changing rural food availability. This takes us quickly into the structural level of our ecological model, but while we're still here on the farm level, US farms have been moving from raising and offering lots of types of crops and products to being specialized. One indication of that comes from the 17 different crop and livestock products that the US Department of Agriculture monitored throughout the 20th century and beyond. US farms changed from in 1950, when they produced over 4 products per farm, down to producing just a lone product per year now. Similarly, research into landscapes and land covers also chronicles falling crop diversity, with the Corn Belt that we are in now having the lowest regional crop diversity in the country. This is not to say we don't have diversified farms anymore. Farms with diversified products that raise and sell us food directly are huge rural assets. They and the farmers markets and food hubs that aggregate the food they grow strengthen my team's food as medicine programs. And worldwide, most of our food comes from smallholder family farms, so we need to listen to them and give them more support. Incidentally, one review of literature finds that for every dollar spent on local food local food as part of food as medicine programs, translates into $3 to $4 that recycles in the local community. So local food networks are a good investment. Here we move from the farm level to the structural level, because over the past century and longer, US agriculture has transformed in response to changing technologies, policy incentives, and market incentives that have converged to inspire us as a country, and especially as a region, to place nearly all of our eggs into one basket. And that basket contains just a few feed grains, corn or maize, and more recently, soybean. These crops inspire our attention as a country because they are amazing plants that humanity has been tending for millennia. They produce a meal and an oil. They yield well. They are sweet, and they can be transformed into lots of different products. They can go to feed birds and animals, which in turn produce food for people like clockwork. They dry on the vine, and they don't weigh very much. And their soybean and corn seeds and the chemicals that keep nature at bay can be patented and earn you money. So these crops attract a lot of interest. This figure shows in red and light blue that the US produces a third of all the world's soybeans and corn. But there are consequences we did not foresee, as our country has spent decades investing in feed grains to the exclusion of nearly all other Midwestern food crops, and great concentration in the other crops. One of those effects is that farms now are feeding people very indirectly rather than directly, and so food deserts are part of farm country. So in general, we used to have a lot of diversified farms that probably sold food locally. We now have fewer farms that are larger and likely to sell into global commodity food chains. This figure carries us from 1850 to 2017. It shows that we have had about 1 billion acres in farms since about 1900, but a lot of farms have closed, which is the blue line. Their land has consolidated into and become part of the farms that have survived. Surviving farms have, on average, more than doubled in size. This is the green line. These changes have also meant that farms often need fewer workers, which has pushed a rural to urban diaspora in our country and everywhere around the world. Now, moving to our final level, retail. I just love this cute picture in her butterfly mask. Okay, so we have data about this from 1990 from the USDA, which I'll show next. But in general, with time, rural families are buying less food from grocery stores, more food from supercenters and dollar stores. As a result, the food options are concentrating and consolidating and are located farther away from people. So the drive times and distances are longer, which is challenging because few rural places have public transportation and gasoline and cars are not cheap, nor insurance. From the store's perspective, it's really tricky to sell raw perishables. And something very valuable for all communities is options where we can process and cook and add value to locally grown food. And this figure shows us how since 1990, the gray line shows us how much supercenters have expanded and taking more of our food dollars. The yellow line shows us how dollar stores have expanded. And the blue line at the bottom that has a very gentle slope shows us how the decrease in grocery stores in rural places. This decline in the diversity of food produced and the merging of farms and dual incomes and people having no land, not farming, people used to be able to rely on one another and or their own land for food. And so this merging over time and transformation of agriculture in rural places has removed that as a reliable source of nutrition from one another. So there are ways in which consolidation of agriculture and retail is creating greater isolation among people, even though people's networks are still very strong and are a huge asset, as one of the speakers earlier this morning mentioned. So it was a good challenge for me to put together this talk to apply the things I've been researching to offer some explanation of the issues of food in rural communities. And this slide just shows a list of other major factors that I could have gone into. And in orange, I'm inviting your suggestions during the Q&A of things you would have nominated as central to this topic. Okay, so just a few recommendations on ways forward in building rural food access at each of the levels. One, at the household level, food as medicine is a great investment. Like I told you, our programs, which focus on sourcing as much locally grown food as we can and supporting Indiana farmers in that way, connects to literature, which shows that every dollar spent on local food for FIM transforms into $3 to $4 as it recycles and circulates in the local community. The evidence base is strong and growing that FIM deserves to be covered by medical insurers and employer benefit packages as competitive in health effectiveness and cost effectiveness as interventions that are always covered, such as pharmaceuticals. At the farm level, we need to deliver much more support for farm product diversification, with one backbone of that being staple foods that grow on perennial plants like trees and shrubs that are always in the ground. On the retail level, we want to support stores and our institutions, such as cafeterias, in sourcing local. And we want to support community commercial kitchens that allow people to take locally grown food, make it into a prepared food, and start a business by selling it. Then at the structural level, we need subsidy and policy support for diversifying farms, for aggregation of value close to the farm, and for quality farm jobs. And I meant to provide a link to a paper we just wrote about this, but I forgot. So if you want it, let me know. That's the end of my talk. I want to give thanks to a bunch of people whose work contributed to the ideas I pulled together here. I especially want to lift up Chelsea Simpkins, who's with you in the room. And here's my email address if you want to get in touch with me. Thanks a bunch, everybody.
Woohoo. Thank you so much, Julia. Can I get another round of applause for all of our speakers? Kari, Kristina, Julia, beautiful job. Laying the groundwork for the rest of our conversation today. So we have about 10 minutes, and there is a lot of brain power in this room. So we want to make sure there's opportunity to start a discussion. I've noted down a few questions, but I'd invite anyone here in the room to ask a question to our speaker or to add from your own personal experience to the dialogue. I think the goal of today is to get some juices flowing, get people thinking about what's next in this work. So I'm going to open up the floor. If you're sitting at a rectangular table, I think you have a mic on your table, so feel free to hit the button and add something in. And I'll give you a second, but I've got a few questions if we're waiting a minute. So anybody have something they want to start us off with? Let me give you a prompting question then. I'm just going to steal Julia's to start with. She gave us a beautiful explanation from her perspective and research on what are some of the contributions to food deserts in rural farming country. But what have you experienced in your work that might be contributing as well that you'd want to add to the table for our discussion? Is there anything that comes to mind? Y'all are a tough crowd this morning. Well, then let me kick it back to Kari and Kristina. You both mentioned at the beginning, or at the very end of your talks, about some of the assets and some of the innovation that's happening, but you didn't really have much time to get into it. So I'm really curious, what are you seeing on the front of making advances in food as medicine, but also just healthcare in rural Oklahoma? What are the things we have to look forward to? And I think, Kari, you have a mic there, and Kristina, I'll bring you one. So Kari, looks like you want to kick us off? Kristina, I'm going to hand it off to you then.
So innovations in food as medicine, we do have a models and innovations section on our website. So I'd just give that a quick plug. And we've seen examples, and I feel like we're seeing more frequent use of some of these examples where they are doing maybe a prescription or produce prescription program in the community, or teaching people how to cook healthy meals, seeing that a fair amount. Other things, and some of it's food security, and some of it's more towards the healthy food. But an example in Minnesota, where they are actively asking questions about, do you have access to food in the clinic setting? And if they don't, they have like an emergency food box that they can give, just to make sure that they have food in the present, and then can work with them to access food other ways. And farmers markets, where in helping people access that healthy food in farmers markets if they don't maybe have the means to purchase the fresh produce. So yeah, I think we're seeing kind of that evolution start in rural communities, and really thinking about the nutrition aspects of disease, where, and how can we help people fill these gaps in their diet, and working with people who maybe aren't willing to make drastic changes, and how can we make incremental changes? So.
Thank you so much. And I see a hand up, so if you want to, Adrian, take the mic there, and we'll riff on that. You got to hit that little button at the bottom. There you go.
Okay, my question is for Kari, I guess. So at the end of your talk, you talked a little about how some counties in Kansas showed really high rates of social connection. And I'm wondering whether there's any data to support that those counties might also have experienced better health outcomes.
Yeah, that's a good question, and it's not one-to-one, but there are, as a factor that influences health and the way the county health rankings, for those who aren't familiar with them, there's two sets. One is the factors that influence health, social determinants of health, et cetera, and then the actual health outcomes. Some evidence there, absolutely. That's at least something that could be leveraged with that higher level of connectedness tend to be in counties that have, among rural counties, rank a little bit higher also on health outcomes. But it's not, I don't know if we can call it causal, right? And it's not 100% too, because there are other challenges also in those communities. Yeah, that's one of the things we think about, both not just and we talked about institutions before, maybe it's faith communities, maybe it's the schools that remain that are also the centers, can be the social centers in rural communities. In some rural communities, though, it's a challenge when you have had, and by necessity, population have consolidations and so on. So, that measure also includes things like social clubs, but also, does it have an active senior center where congregate meals are served and that sort of thing? So, I can't speak to whether we would say, I wouldn't want us to say, if you have that higher rate, then you have 100% better health outcomes in your community. There's so many other factors, but the evidence, the reason it's one of the factors that's included is the higher that is, their overall in the overall population, that does improve health outcomes. Yep. That was a very long way to say, yeah.
I see a question over here. Do y'all have a mic? Here, I'll just take that one right there.
I just have a question on kind of quality of life measures. So have you seen good examples on the innovation side of, there's a lot of research put into biomarkers and health indicators, which is obviously critically important. But in these communities, as you mentioned, the social connectiveness aspect of it, have you seen any great examples of things we should be thinking about in terms of quality of life measures and how to uplift those measurements?
I'll take a shot at it. Maybe I'm going to really segment it to a specific population only because it's top of mind today and some other work we're doing. I think we see some work on quality of life for age-friendly communities, and really thinking about how rural communities that may not have, all of the built infrastructure that would support being able to stay in your homes and stay in your communities as long as possible. There's some communities that are trying initiatives to really, and that's backed by the AARP and other organizations as well, to build up age-friendly communities not just in rural communities, but with the particular challenge in rural areas. So I think one of the measures, it's not in like county health rankings, but it's also just walkability and the ability to move around and get around the community when you don't have car or an access to your car, or perhaps not driving anymore. So I think that's one of the things that communities are really looking at for quality of life, for aging and lifespan, not just for the older population, but across that's also important for kids and communities and welcoming families into rural communities. There's a project that through Blue Cross Blue Shield of Kansas, KHI, and others help support the Pathways to a Healthy Kansas that works with community organizations, and not just in rural communities, it's all across the state. But some of the initiatives, some of the community-based organizations really focus on that. How can we make our communities more livable across the lifespan, as well as things like mobile food, mobile groceries, and experiments like that as well.
Thank you. Okay, and I got one to add over here. So I think we got 1 minute, so we're going to let Cassandra round us out.
Yeah, thank you. I'm Cassandra Nguyen from University of California, Davis. And so I want to bite at Julie's invitation to add to the list, because I feel like it's come up in a couple different comments as well as a presentation this morning about farmers markets. And as somebody who's lucky enough to be in California, where there's a plethora of farmers markets and lots of fresh, delicious food, I'm glad to hear that it's also being brought up here as a potential place where we can connect individuals with fresh, healthy food. And so I think one key piece to think about is the work that we do to make farmers markets appealing and accessible to a variety of audiences. They have a kind of a reputation for being elitist places. And so I want to share that we're working on a policy systems and environmental kind of initiatives review, looking at work that can be done with farmers markets to increase the acceptance and appeal of using food assistance benefits at farmers markets and addressing some of the barriers that we know low-income households are addressing, but also plugging that healthcare facilities, such as our WIC facilities, can really serve as important kind of connectors in addressing these barriers as well, to get that money to local farmers and healthy food to a variety of households. So, yeah.
Thank you, and I think there's a lot of agreement. Julia? I think you got one response, and then I got to close this out because I know we're tight on time.
Go for it. This has been a really great session. It's an honor to be in the room with so many rural health luminaries. Thanks, everybody.
All right, I know there was a ton of conversation that wanted to start right at that, and it does not have to stop here. The whole point of being here today is so y'all can talk to each other. So make sure you find whoever you wanted to add to and continue the dialogue, and I'm going to hand it off to Elizabeth to close us out.
Thank you, thank you, thank you. Okay.